Hello friends and welcome to my video. It has been a long time since I have posted a video, but I was just preparing for different topics, and today I am going to talk about asthma. I think it's a very important topic to discuss because there are a lot of doubts about asthma diagnosis and management equally. As you know that asthma is a chronic disease and it's very common among children. About more than 300 million people are suffering from asthma worldwide, and unfortunately more than 80% of death related to asthma occurs in low and medium income countries. Thankfully, the treatment and prevention of asthma can defer those asthma related death. My name is Dr. Pramod Kumar Agarwal and I'm one of the physicians working in Ireland. As you know me from my previous videos and on my channel Doc on Screen, I post videos related to medical conditions and I am very interested in public engagement. In this video, I am going to talk about diagnosis of asthma. I am going to talk about different treatment options available for asthma, and I will focus mostly on the challenging diagnosis of asthma in children. To know more about asthma, continue to watch this video. Now let's talk about asthma. How would you diagnose asthma? Asthma is a very difficult diagnosis because it presents differently in different people. They are what we call phenotypes. So there is variation of phenotypes exists in asthma. However, there are some complaints or symptoms which are very typical of asthma, and they are wheeze, chest tightness, cough and shortness of breath. They are very typical of asthma exacerbations. So the guidelines suggest that there are two criteria which should be met for diagnosis of asthma. One is the typical presentation of asthma, and second is the variable airway expiratory limitation. So airway should be limited in the expiratory phase and it should be variable. So that's typical of asthma, that the symptoms vary in intensity and symptoms vary in time. You might have heard another disease called COPD, chronic obstructive lung disease. And it is different from asthma that in COPD there is a fixed airway obstruction, whereas in asthma there is a variable expiratory airway limitation. To confirm that, there is a step-by-step process to diagnose asthma. The first step is a proper history taking and the symptomatology. If a child or a person presents with symptoms that are very suggestive of asthma, you go ahead and do a thorough history and thorough examination. After that, you think, okay, that's suggestive of asthma. The symptoms are variable. There are variation during day to day. There are some precipitating factors. For example, sleep, for example, laughing, coughing, or exercise. The child or the person becomes breathless, or the cough or chest tightness. Those are very typical of asthma suggestion. Then you go ahead and do the test for airway reversibility or airway limitation variability. How do you do that? How do you document that? So there are two ways you can check for expiratory airway variability. One is lung function test, where you are looking for FEV1, forced expiratory volume 1. So that's how much you can exhale in the 1 second. And that is done mostly in a laboratory settings or in a specific hospital settings, or what we call a pulmonary lab. The other way would be to look for a blow test or a peak expiratory flow rate, where you blow in a cylinder and with marks on it. And if you say there's a change or there is a variability, then you can diagnose asthma. So I'm just going to quote some numbers here. For the test I said that done in the lab, in lab settings, if there is an increase in more than 200 milliliter after bronchodilators, that is very suggestive of asthma, because that wouldn't happen in COPD. Or if you are using what I call the blow test or the peak flow test, if there is a change of greater than 12% after using the bronchodilators, that is again very suggestive of asthma. So now that's the way you diagnose asthma. So it can be diagnosed. A mother can tell easily that my child has symptoms, he's coughing, is a dry cough, is very out of breath when he exercises. Yes, you can say it is asthma, and then you can do further assessment and further tests to diagnose asthma. Now that you have diagnosed asthma, let's move to the next stage, is the treatment stage or the management stage. So asthma management is very challenging. As I said, it should be a very holistic approach looking at the asthma management. All the stakeholders, the patient, if the parents are involved, sometimes the school teachers, the coach, the football coach, or the exercise trainer, and the doctor, they should all sit down and have an asthma care plan together. It should look not only on the medications but also on the lifestyle, also on avoiding any precipitating factors. For example, if there's a pets, if there are patient is allergic to dust or pollen, try to limit those exposures. Or if there's a smoker, smoke can precipitate asthma exacerbation, so that should be avoided. And then going on the medications, so you're looking for different medications. Here I'm going to start with a very important message, and that is very fundamentally changed from what we used to thought in the past. In the past, we always think, okay, there is this medication called short-acting beta agonist. The examples are salbutamol or terbutaline. You might have heard of inhalers, for example, Ventolin or a blue inhaler. In the past, they were the cornerstone of the treatment. Okay, there is a blue inhaler, take it when you need it and all will be fine. But no, that has been changed. There has been extensive work going on and has been done to find out why people still die with asthma. Although they are using their inhalers correctly, although they are taking it as needed, so definitely we doctors were doing something wrong, that people were still dying with asthma. And that's why the new recommendation come out. Again, you might recall in my first talk that asthma is a chronic disease, and then that's why what happens is after some time the airway becomes non-responsive to short-acting beta agonist. And not only that, it makes airway more prone, more responsive to exercise-induced hyper-responsiveness. It also makes other cells more prone to get activated quickly, what we call the mast cell sensitization. All this together, poor responsiveness, more activeness during exercise, and the inherent biological change to become mast cells more reactive, makes single use or only use of SABA not good. I'm going to quote here a research which was done in 2014, where what they found very sadly, that of all the deaths occurred which were asthma related, about 9% of the patient, so 1 in 10 were using only the blue inhaler. And not only that, about 40% of them were using the blue inhaler frequently in the previous 3 months of dying. So you can see that about 50% of the death were attributed to using short-acting beta agonist alone, which is not good. We should be doing better than that. Now let's talk about treatment. So in the following minutes, I'm going to divide the treatment into 3 different age groups. One will be 5 years to 11, less than 6 years. The second group will be 6 years to 11 years, and other group will be 11 years and older. As I said, the asthma management is very typical and very complex. So that one classification is the age group wise. Other classification is the classification of inhalers. One is called a controller and other is called reliever. Other thing is to treat asthma in a step-wise fashion. So you can start in any step and then go up and down. So, and that will again depend on the symptoms the person has. Really know about treatment, we should know about the inhalers. One. Second thing, we should know about the age group of the initial treatment. And third, we should know which step the patient is. Now let's start with the step-wise treatment. So there are 5 different steps for age 6 to adults, and there's a different steps for 6 years and younger. So the steps are step 1, step 2, step 3, step 4 and step 5, and they are up titration depending on the symptoms. So step 1 is the minimum symptoms and step 5 is worse. Step 1 is when the person has less than 2 episodes of asthma exacerbation per month. They are fine, they are doing okay. So they are having 2 exacerbation per month. Okay, we can manage them. We can try with the inhalers. We can try to change the other modifiable factors. I'm going to talk about that in a minute again. The step 2 would be more than 2 exacerbation per month, but not daily. And you can imagine the step 3 would be a little bit higher. So the person has symptoms almost every day, but there is no nighttime awakeness. As I said, the bronchial epithelium is variable and they are tighter at the nighttime. So if they have asthma and they are tight at the nighttime, the person will find it difficult to breathe and he will wake up coughing or holding his chest or her chest, saying, oh, she might say, I'm finding it difficult, might sit on the side of the bed. So that's why that is step 3, that is bad. And step 4 is that when they have the symptoms of step 3, like they have symptoms most days and they have nighttime awakeness, but they also have documented reduced lung volume. So the lung has shrunk. That is again because either poor management or the asthma diagnosis was not made. And step 5 is there when all these symptoms occur and step 5 is when the symptoms are those of step 4 and so, but not being controlled with any treatment. So then we need a specialist input there. So now let's talk about adults 11 years and older. How would you treat step 1? So as I said a few seconds ago, the step 1 is when you have less than 2 episodes per month. So in that case, again, this is a fundamental change. So please listen carefully. We are not recommending short-acting beta agonist like the blue inhaler, Ventolin or Terbutaline alone. No. Here we are recommending use either as required inhaled corticosteroid with formoterol, or other option used will be whenever the short-acting beta agonist is used, use inhaled corticosteroid, and you can have the reliever, the short-acting beta agonist as a reliever. But for control, it's very important that you should have a puff of inhaled corticosteroid. And I think the reason we are reluctant to take corticosteroids is we think, oh my God, it's steroid. What would be the side effects? Should I give it to my child? Should I continue it for how long? Well, trust me, the side effect of inhaled corticosteroids are much lesser than having the asthma exacerbation or eventually hospitalization or dying, where they will end up getting either intravenous corticosteroids, which has systemic effect, which is side effect. So if the inhalers are used correctly and appropriately, they are safe. Now let's move on to second step. Again, the second step, the preferred treatment would be as required inhaled corticosteroids with formoterol or regular low dose corticosteroid. And you can choose, if you don't want to take corticosteroid, you can try a leukotriene receptor antagonist, for example montelukast or zafirlukast. They are good, they can work, but again they should be reviewed. Like any asthma, they should be reviewed for efficacy and they should be reviewed for side effects. I will talk about montelukast or zafirlukast, that leukotriene receptor antagonist side effect, in the subsequent minute. So I hope you understand this two fundamental change in step 1 and step 2, because that's where the debate was. We are using short-acting beta agonists in these 2 steps, but that's not true. We are throwing in inhaled corticosteroid very early in the asthma management. And then step 3, step 4, step 5, there's not much change, and it is the same, using low-dose regular inhaled corticosteroids with any long-acting beta agonist. And then step 4 would be medium-dose inhaled corticosteroid with long-acting beta agonist, or the other option would be high-dose corticosteroids with a leukotriene receptors. And step 5 is high-dose inhaled corticosteroids with long-acting beta agonist. And then at that stage, you might be thinking of refer to the specialist who have special interest in asthma management, who can do phenotyping for different type of asthma, like eosinophilic asthma, non-eosinophilic asthma, or they can be assessed for candidate for different newer agents, or what we call biological agents, so that you can reduce the overall burden of corticosteroids. So this was the treatment for age group 12 and above of different step by step. Just to recap, the preferred treatment for step 1 would be as required inhaled corticosteroids with formoterol. Step 2 would be the same, as required inhaled corticosteroid with formoterol, or you can use daily low dose of corticosteroids. Step 3 is low dose corticosteroids with a LAVA. 4 would be medium dose corticosteroid, inhaled corticosteroids with a long acting beta agonist. And step 5 would be high dose corticosteroids with a long acting beta agonist. I'm going to pause here. If it's step 1 and 2, don't rely on short acting beta agonist if they are adult or adolescent, because as I said, it does causes the asthma related death and asthma related hospitalization. Second point here is treat asthma as a chronic disease with a holistic approach. You should take into consideration the person's, he or she, if she is using inhalers correctly or not, if she has other modifiable risk factors. Review them regularly, not only during exacerbation, but also during a chronic management. See if they are doing fine. Do they need to step down their treatment or not? And again, that's why the step-by treatment. You can just simply ask about the symptoms and then up titrate or down titrate the inhalers. Now, let's move on to the second group of patients, which will be between age 6 and 11 years of age. Again, the treatment is subdivided as reliever or controller. Treatment is subdivided into step by step 1, 2, 3, 4, 5, and as treaties as a chronic disease. So step 1, there is not a preferred treatment for step 1 as such. And the other, if there is not a preferred one, because there is no evidence, we don't have any trial looking into that age group where we can try different inhalers and see. So unfortunately, there is a knowledge gap there. And in the absence of knowledge, we are recommending that use low dose corticosteroids whenever the blue inhaler or the short acting beta agonist is used. And then you can have the reliever as a short acting beta agonist. And then step 2 will be regular use of inhaled corticosteroid. And then step 3, 4, 5 are the same as adult. So you can up titrate the dose of corticosteroids and using a long acting beta agonist. Don't forget to have regular assessment and the holistic approach. Now I'm going to move to a very complex age group of asthma in 5 years and younger. So why I say it's very complex to manage asthma in younger children? Its obvious reason is this compliance of doing the test. So they cannot do the peak flow very well, or they do not do the full lung function test. So the variable expiratory airway quantification can be difficult. There could be a lot of other conditions which can mimic asthma, which can make the diagnosis a bit challenging. And again, it's very difficult to review a child often as you would like to do for asthma management. But having said that, there are some peculiarities of asthma which suggest or which will direct us that is asthma rather than anything else. If the symptoms are typical of asthma, as I said, if there's a wheeziness, if there's a chest tightness, if there's a dry cough, or there's shortness of breath, and again, if they're variable during days or nights, if they're variable during exercise, or they're during activities, and in the absence of any other infection, yes, it's suggestive of asthma. Or it can do a diagnosis of a proxy. You can give them a short-acting beta agonist, which will relieve the airway, and if the child she finds is helpful, yes, it was asthma, and we can treat them, in a step-by fashion. I'm going to talk about differential diagnosis first of asthma. That there are a lot of differential diagnoses, and one is most common is what we call viral induced wheeze, and they can mimic like with wheeziness, which can be variable wheezy, can last up to 10 days. But other symptoms which will direct us, or which will indicate that it's not asthma, is something else, is that the child will have runny nose, or child would have some viral flu-y infection. Other could be structural deformities like what we call trichomalacia. Congenital heart disease is common. Common infection like tuberculosis can mimic, bronchiolitis can mimic. So those things has to be taken into consideration if the child is not responding to initial treatment. And as all asthma, treat asthma as a chronic disease. Please take on board all the stakeholders, parents, the child, the carers, the healthcare providers, reassess them for their inhaler techniques. And as you can imagine, child would not be holding the inhaler, so they should be using a proper spacer, and then they should be breathed in and out in the spacer regularly, and that would come with the compliance and the trust if they get relief and they get beneficial effect. So now move on to the management or the treatment, the pharmacological treatment of asthma. As I said, you can treat them in a step-by fashion, and depending on their symptoms, you can start at any step. In children, we are very low threshold to refer them for specialist assessment. So we are already referring them at step 3. So step 1, there is not major treatment. They use short-acting beta agonists as needed. And step 2 would be low dose inhaled corticosteroid. And then step 3 would be use double dose of inhaled corticosteroid. And step 4 would be high dose of corticosteroid, but you are thinking of referring the child already when they have nighttime awakeness or they have symptoms most of the days. That is in step 3 and step 4. Because it is a chronic disease, and if you liaise with the specialist early in the disease, they can be followed up, and that improves the compliance, that improves the management of asthma. So that's why it's very important that refer them early for specialist assessment. Now I'm going to talk a little bit about leukotriene receptor antagonists, but there is some caution about montelukast. It should not be used as a general anti-allergic tablet like you are using cetirizine or levocetirizine or chlorpheramine. It's not recommended for allergic rhinitis. And why is that? Because montelukast has shown some side effects, and especially the mental health part is very devastating. It has been shown that it increases the neuropsychiatric events in children, and it increases the suicidality, and it causes nightmares. So that's why if you are prescribing or if you are taking montelukast, please make sure that you are aware of the side effects and you are followed up regularly. I'm going to talk now a little bit about COVID. Now that we are in the COVID pandemic, unfortunately, we are still fighting with it. And there are a lot of questions I'm getting about asthmatics and COVID situation. If they get COVID, what should we do? And should they stop taking their medication and precautions and etc. The recommendation so far is that do not change anything during this COVID pandemic, or if you have been found detected SARS-CoV-2 virus. Do not stop your inhaled corticosteroids. Do not stop your oral corticosteroids if you are on them, or do not stop your biological agents. Because trust me, the risk of dying from asthma exacerbation or hospitalization of asthma is much greater than getting full-blown COVID-19. What is recommended is avoid nebulization, and it's same for other chronic diseases, for example COPD, that or pneumonia who they need nebulizing therapy. The nebulization generates aerosols, and aerosols can infect the healthcare professionals. An alternative to that is use the meter dose inhaler with a spacer. So you can use the high dose of the medication and it will be delivered very effectively and efficiently through the spacers. Now I'm at the end of this topic. In the next 30 seconds, I'm going to summarize this talk. Please consider asthma as a chronic disease. Check your children or she or he to get reviewed asthma regularly. Go to your healthcare professionals very regularly, not only during the exacerbations. 2, if you are, or if your child or anybody is only on single or only on short-acting beta agonist, please check that as soon as possible, because only short-acting beta agonist is not recommended for adolescents or adult. And then what I would like to say that take a holistic approach in the management of asthma. Bring all the stakeholders together, have a regular asthma review, start management where is needed. It could be at any step, and then down titrate or up titrate. And lastly, don't be afraid to take inhaled corticosteroids because they're not as bad as they are portrayed to be. If they are taken rightly, if they're taken efficiently, they are very helpful. So I hope you like my video. And if you have any comments, please leave the comment in the box below and I will be delighted to discuss it with you. And please do not forget to subscribe to my channel or hit the like button. See you in the next video.